periodontal disease, you have risk factors, right? You have etiologic risk factors. Now, periodontal disease is multifactorial, which means it has lots of things that come together to create it. You can have hereditary risk factors, such as something you inherit, an immune deficiency or a genetic syndrome, like Down syndrome. You can have systemic diseases that link to periodontal disease, such as diabetes. You can have certain pathogens in your mouth that can cause periodontal disease. The ones for perio are AA pathogens, which are acetomycetemicomycetans, and then the Tannerella, Fusarrhea, and the P. gingivalis. You can also have social atmosphere, which can enhance periodontitis. The way you're brought up, your culture, your money factors, if you can afford care or not, if you have insurance. And then you have personal habits, such as how well you brush your teeth, how often you're going to the dentist. Do you smoke? Do you drink alcohol? Do you eat really poor foods? All of these things, again, contribute to a multifactorial disease, which is periodontitis. It's basically a gray area. Biologic equilibrium, a state of balance in the body. So you have a scale when you think of biologic equilibrium. Our goal for it is to make sure the health aspects are either balanced or superseding. So this side of the scale you want to be straight across or even up higher. So let's look at the scale. On the healthy side, the biggest thing that's going to keep you healthy is at-home care, periodontal instrumentation, surgery, chemical agents to reduce your bacteria. Then you have host modulatory therapy, resolution of inflammation. And then you have expression of host-derived anti-inflammatory protectors, or enzymes. And then reduction of risk factors. Those are all going to contribute to the health side of periodontal disease. Now, the disease side of the scale. Poor compliance, poor plaque control, subgingival biofilm. Those are the number one things that are going to cause it. Underactivity or overreactivity of the host response. So if your body is quick to create overzealous repair, that's an issue. Overproduction of pro-inflammatory or destructive mediators to enzymes. And then diabetes, smoking risk factors, all of those things. What's one of the easiest ways to stop inflammation in your mouth? Your diet. Sugar is the number one food that causes inflammation in your mouth. If you avoid sugar, you're going to avoid less inflammation in your mouth. So let's keep going. So now you have local contributing factors. These are things locally in the mouth. So again, oral conditions or habits that increase your susceptibility to perio. Our role as dental professionals is to minimize this contributing factor. So, local contributing factors found in the mouth. Local contributing factors do not initiate periodontal disease. They just contribute by adding biofilm. Local contributing factors may increase the risk of developing disease or more severe disease. So how do they increase the risk of disease? Local contributing factors can increase the risk of biofilm retention, such as having a rough edge on a restoration. If you have biofilm that's having a lot of pathogenicity due to lots of calculus not being removed and it creating homes for the biofilm. And also, if you have heavy chewing or bruxing, you can cause direct damage to the periodontium. These are all contributing factors to the risk of disease for perio. So, we're going to group these into groups so we can better organize them. So, these are local factors that increase biofilm retention. What happens in your mouth that can increase retention? calculus and the way your teeth are shaped, tooth morphology. Calculus is not living. It's not bacteria. However, it's porous and creates a home for bacteria to go in and live. So that's one way it increases biofilm retention. Tooth morphology. The way our tooth is shaped, if it has lingual grooves, concavities, etc., is also a really high magnet for biofilm. That increases biofilm retention. Calculus. Calculus in this picture is covered on the external surface by living biofilm. So biofilm can cover up calculus. Calculus deposits and plaque retention. So the surface of calculus is irregular. It's rough, which means it is a nidus or a home for bacteria. Calculus is always covered with disease, causing bacteria. If you remove calculus, you're removing homes for the bacteria. Alright, attachment to tooth surface irregularities. So again, this is what we talked about with tooth morphology. Cracks in the tooth surface, tiny openings, grooves in the cementum due to over-instrumentation. That can be an issue. Deposit removal is difficult because deposits lie in sheltered tooth defects. So it's hard to clean out tooth morphology issues because that's why they're so good at retaining biofilm, is they are hard to clean. And then also rough scaling can cause microdamage, and that's important to remember. So be aware of your angulation and instrument of choice. Alright, attachment directly to tooth surface. The matrix of calculus deposits interlock with organic crystals of the tooth. Then they deposit firmly interlocked into the tooth and are difficult to remove. So that's important to remember. Tooth morphology we talked about. Other issues with tooth morphology: poorly contoured restoration, untreated tooth decay, and grooves and concavities. So there's a picture of a poorly controlled restoration. Untreated tooth decay harbors periodontal pathogens. And also be sure to check subgingivally to feel for large cingulums that hide biofilm. Same with large buccal grooves. It's important to know that nothing can stick onto an enamel pearl, but bacteria can harbor around it. Root concavities, those also can hide biofilm. They're hard to reach, especially because flossing does not dislodge the biofilm in root concavities. You need an interdental brush to be more effective. Pathogenicity, or the beginning of pathogens and disease. Plaque biofilm maturation. Large quantities of bacteria present in undisturbed accumulations. More pathogenic bacteria arrive and colonize and can be associated with biofilm retention factors. So, factors that cause direct damage to the periodontium. Cause of direct damage to the periodontium. Food impaction. Patient habits, if they're not using their aids correctly, tongue thrusting, mouth breathing. Faulty restoration, such as crowns with biological width, contours, prostheses, and then occlusal forces. We talked about in class the emergence profile, which is the way food debris bounce off the occlusal surface perfectly, just enough to stimulate the gums and clean the biofilm, but not enough to retain biofilm. Well, if the crown margins are too big or too little, the emergence profile is affected and food can no longer bounce off perfectly and instead will cause issue to the surrounding tissues. Here's an example of food impaction between teeth. Food impaction can strip gingival tissues away, can lead to gingival contour alterations, which are difficult to clean. Patient habits. So if patients are using toothpicks improperly or floss improperly, you can blunt the gingiva, which can retain food. Also, tongue thrusting can affect the periodontium itself and break it down. Myofunctional habits, like if they're grinding or bruxing, stuff like that. Biological width we kind of talked about with the emergence profile. But basically, In order to have biological width, you need crown margins that are closer than 2 millimeters to the crest of the alveolar bone. Let me repeat that. Biological width is having at least 2 millimeters space. The tooth needs 2 millimeters of space away from the bone. The crown margin needs to be 2 millimeters away from the bone to not cause any problems. If you have a crown margin that is closer than 2 millimeters to the crest of the alveolar bone, you begin to have encroachment on biological width, or resorption of the alveolar bone. The bone then migrates away from the crown because it doesn't want to be near the crown, and the gingiva begins to find new places to attach. Also, if you have a crown that's a lot deeper than the biological width that it should be, it's more difficult to clean because the margin is deeper in the gums. So here's an example. In health, biological width is 2 millimeters, like we talked about. The space on the tooth surface is occupied by junctional epithelium and connective tissue. So in the first picture, you have a healthy restoration. The crown margin is 2 millimeters away from the alveolar bone, biological width. Second picture, the crown margin dips way past 2 millimeters and is affecting the biological width, which is causing not easily cleanable teeth, damage to supragingival fibers, inflammation, and redness. Now, you can have a procedure done that helps solve this problem, and it's called crown lengthening. So basically, when decay reaches past the margin that the new crown should go, you have surgery where bone and tissue is brought down so that the crown margin is perceived as bigger, and you manually create the 2 millimeters of width yourself. So first picture, you can see a crown margin on the root of a tooth that is way too low. Crown margins should not hit the roots of the teeth. That's way past 2 millimeters biological width. Picture 2, you can see inflammation from the gingival margin where the crown is too deep. And you can also see it radiographically. If you have really bulky crowns, you create inadequate space for the teeth, and this causes papilla enlargement due to it being squeezed tight between the teeth. Prosthetics. Prosthetics also harbor biofilm and destroy the periodontium. You can have damage to your periodontium from prosthetics. Here's an example of a removable mandibular partial where the clasps are anchored to the canine and they are damaging the tooth. Orthodontic wires is traumatic. Ortho causes trauma to the periodontium because you're moving bone, and if you're moving bone too quickly too fast enough for it to not be able to keep up with repairing itself, it causes permanent damage. And then occlusal forces, such as bruxing and chewing and your bite. So natural teeth are never supposed to come together tooth on tooth. When we chew food, the food we're chewing protects the teeth from hitting each other. And when we talk, our tongue does the same thing. But in abnormal function of teeth, when we chew, teeth end up hitting each other during eating and function. This can cause grinding, edge-to-edge malocclusion, clenching. So you can have functional occlusal forces. These are normal forces produced during the act of chewing. And then parafunctional, which result from tooth-to-tooth contact when not eating, such as clenching or bruxism. So here's more in-depth info about parafunctional occlusal forces. You have excessive force on the teeth and the periodontium. In order to fix this, you need to possibly have occlusal adjustment or night guards. Or you can have preventive appliances, like a splint, bruxism appliance, or a night guard. How do you know if a tooth has occlusal trauma? Well, the tooth could be mobile, because remember, it's like a post in the ground. If you're constantly hitting the post and wiggling it, soon the post is going to be wiggly in the ground. You could have sensitivity to pressure. The teeth can migrate or move. You can have a large funnel-shaped PDL space, and alveolar bone resorption. So here's a radiograph of loss of alveolar bone along the lateral surface of the tooth, and you can see a PDL widening. PDL widening is the first sign of occlusal disharmony. Primary occlusal trauma. Excessive occlusal forces on a perfect periodontium. This can happen from high restorations, high sealants, excessive force on abutment teeth from partials. First thing you see is a wider PDL, tooth mobility or pain, and changes can be reversed if the trauma is removed. Remember, that's primary occlusal trauma. Trauma that is on healthy teeth. And then you have secondary occlusal trauma. This is injury to the periodontium from normal occlusal forces applied to a periodontium previously weakened by a periodontist infection. So, primary occlusal trauma that's happening on healthy, normal teeth. Secondary occlusal trauma is occlusal trauma happening to a periodontium that is already weakened by periodontitis. You can have rapid bone loss because of this and pocket formation, and it's not reversible, but it can be stabilized. Here's a picture of secondary occlusal trauma. Lateral occlusal forces. This is the tipping of the tooth within the socket due to lateral occlusal forces. Damage to teeth with reduced bone height. Teeth with reduced bone height from existing periodontitis. So basically, yeah. Okay, and we're going to stop there. So those are all local contributing factors to periodontal disease, things that are happening in your mouth with your teeth or biofilm. The next video we'll talk about systemic factors, so stuff that's happening in your body that affects periodontitis.